and this has to be continued as long as necessary. We have to be very sure that antibacterials do not need to be tapered off. They are to be stopped abruptly. That is about 6 times a day is the least which we go, and they're not to be tapered off. So to summarize, small ulcer, we generally one can continue to use monotherapy. Allow me to clarify here, at our institute we still follow the combination therapy for small or the large ulcers. If you are using monotherapy or a combination therapy, a close follow-up is very, very important. And once the culture and sensitivity results are available, you need to change or modify the treatment accordingly. And one has to be very, very mindful of the antibacterial resistance, which is very prevalent these days, to have a good outcome. Thank you for your patient listening.
Thank you very much, Mukesh, for nicely comprehending that. So in case there is any question, we can keep after the session. I think Dr. Prashant Garg is online. And Dr. Prashant, can you hear us?
Yes, very much.
Okay, great. We have the course has already started. So one talk has been delivered by Dr. Mukesh on monotherapy versus combination therapy. So over to you, Dr. Prashant.
Yeah. Good afternoon, everyone. First of all, I'd like to apologize for not being there in person because of some personal emergency. But I'm really grateful to all the speakers who gave me the confidence that no, the course should not be withdrawn and we should continue with this course. So I'd like to thank all the participants, Murli, Mukesh, Vikas, Dr. Namrata, and particularly Dr. Namrata, because despite her such a hectic schedule, she gave me that trust and confidence. Now, as you must have already realized that there have been a lot of developments in the last decade which really are making this topic relevant. Whether we should use corticosteroid or not, whether we should, which antifungal drug is better, Voriconazole or natamycin, should we do lamellar keratoplasty for corneal infection or full thickness graft. And one of the topics that is important is whether we should be treating corneal ulcer empirically or should we do microbiology in each and every patient who present to us with a corneal ulcer. And I'll try to give you my opinion and the view along with the review of literature on what guideline we can follow as far as the microbiology in the treatment of corneal infection is concerned. I think one of the important guideline for the management of corneal ulcer is early institution of intensive treatment with an appropriate antimicrobial drug. And here the appropriate antimicrobial drug is probably very crucial. For bacterial ulcer, we need to give antibacterial, whereas for fungal ulcer, we need to give antifungal drugs. Similarly, for amoeba or atypical bacteria, specific therapy is required. Now, if you review a textbook, you will realize that the typical recommendation in textbooks on corneal infection is that all cases of corneal ulcers must undergo a detailed microbiology workup. However, in practice, we find that nearly half to 100% of the cases in some situations are managed using indiscriminate combination of variety of agents or antimicrobial agents along with corticosteroids. So there is a big discrepancy between what is recommended versus what is actually practiced in clinical medicine. So therefore, this question becomes important. Why this kind of a dichotomy? At one end, academic ophthalmologists are recommending doing microbiology in each and every patient of corneal ulcer, whereas in reality, many ophthalmologists are treating them empirically without really bothering to know what is the causative organism. Many of you may a study that was conducted in 1990 in the state of California. They found that 80% of the patients where no microbiology was performed responded to medical treatment. And they wondered why we are seeing such a good response despite physicians not following the protocol that is recommended in a standard textbook. And they found that most of the antibacterials are bactericidal and majority of the cases are caused by bacteria. In addition, there are certain features that helps you arrive at a probable etiological diagnosis. For example, if a disease is rapidly progressive and is characterized by suppurative infiltrate, more likely that this is a disease caused by bacteria. Whereas, if a patient presents to you with a slowly progressive disease and a localized infiltrate, you are more likely to be thinking in terms of fungi or protozoa. In addition, you can look at certain characteristic features that can be a pointer to the possible causative organisms. For example, the presence of pigmented lesion on the cornea is suggestive of infection caused by Demetacea fungi. A white, dry looking infiltrate with hyphae edges is probably suggestive of fungal etiology, and a ring infiltrate is more pointer toward it being an acanthamoeba infection. Now, if it is so, then why are we needing microbiology? However, if you look at the clinical picture that is now shown on your screen, are two patients presenting with a ring-shaped infiltrate, but both of them were not caused by acanthamoeba. They were caused by fungi. There is an overlap of clinical picture that we see commonly in our clinical practice. There was a beautiful study conducted way back in 2005 in Trichy, along with a group in United Kingdom, who asked physicians with 10 years experience in management of corneal infection to make a clinical diagnosis based on clinical feature and corroborated these diagnosis with microbiological diagnosis. And they found that ophthalmologists with 10 years experience were wrong close to 40% of the time in making accurate diagnosis. And therefore, they recommended that ophthalmologists are urged to send corneal scrapes for detailed microbiology workup whenever they are dealing with cases of corneal infection. However, the microbiology workup comprises of lot of activities. They involve taking corneal sample from using either 15 number blade or Kimura spatula, and then inoculating the specimen on variety of culture media that facilitate growth of bacteria, fungi, and parasites. Commonly use gram stain, Giemsa stain, and KOH chalcofluor white for microscopic examination and inoculate specimen on blood agar, chocolate agar, brain heart, abroad dextrose agar, and potato dextrose agar. If you are suspecting acanthamoeba, then you inoculate non-nutrient agar and subsequently overlay this plate with Escherichia coli. Now, what it involves is that in ophthalmic practice, since we are scraping very small lesions, it is recommended that we should inoculate directly the culture plates. Now, therefore, if an ophthalmologist is handling a patient of corneal ulcer and is asked to do microbiology in every patient, then they will have to maintain all of these media and will require help of a trained microbiologist who will be able to interpret these results. If there is a growth of bacteria, then you will be subjecting these to do in vitro antimicrobial susceptibility test using variety of these. Now, in nutshell, what it entails is a well-equipped laboratory, trained staff, and there will be additional cost and logistics. With corneal ulcers most often occurring in people with low socioeconomic status and engaged in manual labor or agriculture, they will not be able to pay or bear this cost. So therefore, most ophthalmologists are treating patients of corneal ulcer empirically and are not performing detailed microbiology. So the question then becomes, is this protocol of detailed microbiology in all cases of infiltrative keratitis is a true necessity? Now, this is particularly relevant because if you realize that most of the corneal ulcer
I think the internet seems to be unstable. Are there any questions to Dr. Mukesh Taneja before again Prashant comes back?
So we are right now we are preparing with the water for injection, but otherwise in my residency days I was using vancomycin. I mean, and so these days we are using it with the water for injection, and people are complaining that it's very stinging. I'm talking about the vancomycin.
The water for injection that I'm also using the same thing. You have to discard the drug every third day. That also
so
becomes
your shelf life would be one day. One day. I mean, if you're using outside in the room temperature, then one day. If you're using in the refrigerator, then about a week.
Okay, I'm asking them to discard it every third day. If it is, I'm using water for injection, but I'm discarding it every third day. And so what is your idea of putting it in refreshed tears or something which will make it more economical to the patient and as well as...
We were routinely doing that. We were using the Tear Plus, which used to come in 10 ml. It still comes with 10 ml. It's perfectly okay to use, to mix it in with 10 ml. It's very convenient because you need 10 ml only.
That's
so it's perfectly okay. I have done that in my residency days. And you get a preservative also.
That's exactly because most of them come from very low socio-economic background.
Yeah, the excellent question. Actually, we still use some of the bases like a preservative-free lubricants, particularly when we dispense PHMB, chlorhexidine. So that could be used for a little longer while. So you have a shelf life nearly about 7 days in those instances. And other thing, we don't use any preservative lubricants, particularly for a broad spectrum antibiotic. We do not want MIC to be diluted. Okay, that's the biggest concern we have.
With preservatives, is it? With preservatives?
Yeah, with the preservatives.
Okay.
You said that people eating chicken are more having resistance. People having chicken.
No, I did not say that. So that ad was saying that when you're giving, because in poultry industry, a lot of antibiotics are used. Okay, so if you would be, if your kids would be using that chicken, eating that chicken, that's not good for them because inadvertently they will be getting antibiotics inside the body, which is not required.
What is your rate of sensitivity and resistance in those patients who have had non-vegetarian versus vegetarian?
Never check that.
Excuse me. Now I'm coming from Bahrain. They are using a lot of stem cell therapy, so they take the plasma, centrifuge it, and give for many things, for chronic pain, angle. So now they are trying for corneal ulcer also, centrifuge serum. Is there any effect for that, for chronic ulcers, non-healing ulcers?
I routinely use the serum drops for dry eyes, have absolutely no ideas about the for a bacterial ulcer. I do not know if they have any antibacterial property.
So for other part of the world, is cefazolin available? Cefazolin, because now cefazolin is largely not available, and we have been using it for gram-positive cocci. I think it's one of the most beautiful drug. But these days we have no other option but to use vancomycin. So what we
Some people have started using cefuroxime. Nikhil Gokhale in Mumbai is using cefuroxime.
yeah.
And there is a literature which is available,
True.
and I think we need to think about cefuroxime. It's the
Cefuroxime
second
also.
generation, while cefuroxime is the first generation. So that probably is a better option than
Absolutely.
using vancomycin, which is a reserve drug.
True.
I believe so.
Ceftazidime. Okay. You're using ceftazidime and you find it good enough. So that's I think that's a good thing that has come up, that people are using cefuroxime and ceftazidime also.
Ceftazidime, is it not used for the gram negative? Yes, because you use a combination of vanco and ceftazidime, so that's mainly for gram negative. So here we want a substitute for gram positive. I think cefuroxime probably would be the way forward.
So my use of chloramphenicol has also increased in last 4-5 months, and I found that is very good. And if you see the sensitivity reports, time and again you see a resistance to moxifloxacin, and as a matter of fact even gefloxacin, but chloramphenicol you see less chance of having a resistance. Okay, so Dr. Prashant Garg I unfortunately lost the connection. So I'll take up the surgical options in the corneal infections and how surgical options can be of help. So first of all, that why surgical management is required in corneal infections. We have good antibiotics, and also why we really need it. So have a look at this. This patient was 45-year-old male. He had a limbus to limbus infiltrate. Underwent therapeutic penetrating keratoplasty and did very well. He is still maintaining his around 6'9", 6'12" vision, and it's now I think 6-7 years, and somehow there has been only one rejection. Another girl who had a corneal melt, status post infection, and underwent therapeutic PK and did very well. So for cases which have known responding corneal infiltrates, or where there is already a collagenolysis, here just using medicines will not be sufficient. You will need to do some kind of surgical intervention for these two conditions. So and with an aim of either getting rid of an infection or provide the tectonic support. So that is what the goal of any surgical intervention in corneal infection is, to get rid of infection or provide a tectonic support. Which type of keratoplasty we use, whether we use lamellar or full thickness, that depends on how deep the infection is. If you feel that the infection is only in the anterior half, or then you can think of doing a DLK, and